The topic we decided is a whole story since at least 2 years with a family support group. We felt that dealing about feeding, nutrition and growth was something very important in these children, but also we will see later on toddlers, adolescents, even in adults. And this is a really multidisciplinary task. It starts at birth, even before birth, when there are prenatal diagnosis for these children. And it starts at time of operation, neonatal setting, and then with a child growing at adolescence, there are different questions and different professional, healthcare professional involved in that care. And we have here, I'm very proud to have here a very nice panel of speakers coming from different countries and different background. We will have psychologists, psychotherapists, nurse, surgeon, PGI doctors, neonatologists. I'm not sure to miss somebody, but and all of them have an experience and will share a part of the picture. And at the end of the session, we will have 2 clinical cases to share with you in type to summarize what we can do or how important is nutrition and growth in the story of such children or adults. And at the end, we will try to have a summary discussion all together and a plan for action. What are the gaps to be filled? What do you think is needed to do after all the discussion we will have there? So it's time to start now. So I'm very happy to welcome Michiel van Wyk from Amsterdam. He is a pediatric gastroenterologist. He is both from ERNICA and ESPGHAN, so it's a perfect prototype of what we have to do, being in every place where the things are moving. And he is one of the specialists on motility, and so the topic is what are the mechanisms of feeding problem in esophageal atresia patients. Thank you, Michiel.
Thank you, Frederick, and thank you to the other organizers. My name is Michiel van Wyk. I'm a pediatric gastroenterologist in Amsterdam, and I'm very honored to be able to speak to you about the mechanisms of underlying feeding problems and feeding disorders in children with esophageal atresia. Feeding and eating should be a happy thing in early life, and in most children, of course, it is, but it can become problematic and can turn into a feeding or eating disorder. And before we go into the mechanisms underlying these, it's maybe good to try and get into a definition of feeding and eating disorders. And although this is a bit of a gray area where people differ a lot in their opinions about what the exact definition should be, I have put one down. Don't kill me if you don't agree. But I think this will work for this talk. Feeding and eating disorders can be defined as impaired oral intake that is not age appropriate and can be attributed to a combination of underlying causes, and those can be either medically driven or functional. And functional in this definition is meant that it cannot be attributed to an active medical disease. 2 points I'd like to stress. First, there's the not being age appropriate. Of course, we all know the toddlers that are picky eaters and don't like to eat everything, or adolescents that do not eat as much vegetables as their parents would like to. These are not the children that have feeding and eating disorders. And also, before we call it functional, it cannot be attributed to an active medical disease, but it doesn't mean it cannot be triggered by a medical disease. So we all know there is children that have a medical disease, and while the medical disease is gone, there remains to be problems with feeding and eating, and they can have a functional feeding disorder. Now, in the general population, feeding disorders are not uncommon, but in esophageal atresia, they are very common. This is a study with 145 esophageal atresia patients between the age of 1 and 4 years. And in this cohort, 42% had a feeding disorder and 13% was tube fed at the start of the study. And if you look at what was going wrong, they had prolonged meal times, low appetite, oppositional and adversive behavior, stressful meal times, and signs of oral hypersensitivity. In other studies, they looked at dysphagia, and dysphagia is not the same as a feeding disorder. Dysphagia is having problems with swallowing, and these studies show that up to 84% of patients may have dysphagia in esophageal atresia, and many of them might even be unaware and still have it. Why is that? Well, children are born with esophageal atresia and are developing coping strategies, and adults have developed coping strategies, so they think what they feel is normal while they in fact might have problems with swallowing. So in fact, I think that not 84% of patients with esophageal atresia, but 100% of esophageal atresia patients will have a form of dysphagia. Not always leading to feeding problems, but there's always a limited amount of abnormality in the swallow at least. What is also important is that we consider feeding patterns that are abnormal, normal in patients with esophageal atresia. A 2-year-old that has only pureed food is absolutely abnormal in the rest of the population, but we all know there are quite a few patients with esophageal atresia that still have pureed food at that age. Now, if we look at underlying causes, let's first look at the functional causes, and I'm not going to go into detail in the functional causes, as you will hear much more about it by the later speakers. But of course, there can be medically triggered adverse events in the first year of life. All these patients are hospitalized, have lots of procedures going on that may cause them to be fearful and have aversion for food. In all children with esophageal atresia, there is a delay in the initiation of oral feeds after birth, and in many of them there is a delay in the initiation of the advancement to semi-solids. Also, parents are often scared to advance to semi-solids, and therefore, for example, positive feedback at that time is reduced and leading to abnormal feeding behavior. Other functional causes that are not specific for EA do occur in EA patients. For example, patients with pharyngeal hyposensitivity, pharyngeal and esophageal hypersensitivity, and so on. The medical causes, I've tried to mention most of them here, are anastomotic strictures. We all are aware of these, but there's also congenital strictures, recurrent fistulas, motility disorders, reflux disease, eosinophilic esophagitis, and from a perspective of a gastroenterologist, it is always good to realize that there's more than the esophagus. Also, pharyngeal problems can cause feeding disorders like a cleft, tracheomalacia, neurological spasm of the upper esophageal sphincter, pharyngeal weakness, and also down the esophagus, you can have a gastroparesis or a missed web in the duodenum, for example. And what I'd like to do in the rest of this talk is to look at some of those direct medical causes of feeding problems in EA patients. Anastomotic strictures, congenital strictures, motility disorders, reflux disease here behind the audience online, and eosinophilic esophagitis. And let's start with the anastomotic stricture. Risk factors for developing an anastomotic stricture is we well known that it can be an anastomotic leak, anastomotic tension during the operation may be a predictor, and there is data showing that the low birth weight, prematurity, and tracheomalacia may also influence the development of strictures later on. However, this is not clear from all studies that we see. There is an assumed relation between the amount of reflux and reflux disease that patients have in their first year of life and the development of anastomotic strictures. However, data from studies do not truly support that there is a causal effect of reflux on the number and severity of the strictures. You touched my screen and now I can't go to the next slide anymore.
Sorry, let me move this.
I understand. Can you go to the next slide maybe then?
Yeah. I will move this first and then go back to the slide to see it.
Here we go.
Okay.
Okay, so if we look at anastomotic strictures, they are absolutely occur quite often. This is quite an old study summarizing the literature up to 2013, but since 2013, the data is not much different. So in these studies, you see a range of percentages of anastomotic strictures, with an average of about 40% of the patients having an anastomotic stricture after an open procedure. This is probably due to the range in definitions that is used for strictures, and also the interpretation of the people that decide, for example, when a dilation is required. Because if you define the stricture as required dilation, it depends on the criteria that you use for a requirement of dilation. After a laparoscopic procedure, it seems to be a little less, but there's less data, and also the data vary very much. So we really don't exactly know how often it occurs, and we don't exactly know what the factors are that predispose to these anastomotic strictures. What can we do with them? If you have a patient with a suspicion of an anastomotic stricture, you could of course do a barium swallow to see if the stricture is there. However, it's also a consideration to think, what am I going to do if the barium swallow is not showing the stricture? Most patients that come in with new developed feeding disorders or new developed dysphagia, and you don't see the stricture, but the patient has severe problems, you will eventually enter up doing an endoscopy anyways, and you might prevent the patient from radiation in the first place by not doing the swallow through. I'm not saying that you shouldn't do it any time, but it is a consideration. Then you can do a balloon dilation, you can do a bougie dilation, and this is what we do in the world. This is a questionnaire that was sent out I think it was gastroenterologists and surgeons, right? Yeah. And this, about 70% do balloons, 17% do bougies, and 15% do both. Is there a difference? Well, there are studies that show preferences for balloon. There are studies that show that bougies are better. This is one of the latest studies where they did a multivariate analysis and they show there is no difference in a retrospective way. So I think the verdict is still out. We do need prospective studies that really compare bougies with balloons, and they are ongoing. But it's very difficult to decide, and for now it's probably best to do what you prefer. Then there's options if this doesn't work. There's local steroid injections, indwelling balloons, mitomycin C can be used as an additive option, but there's no real data showing that it helps. And then as a rescue therapy, you can do incision, endoscopic incision therapy, surgical resection, and replacement of the esophagus. So that is the anastomotic stricture. If we then move to congenital strictures, this is a very rare disease in the normal population. But it does occur quite often in patients with esophageal atresia. So I think it's something you always have to consider when there is a patient with feeding problems. We see reports of up to 14% of EA having congenital strictures. And there's three types: tracheobronchial remnants, fibromuscular strictures, and membranous strictures. And this is a very recent paper that compared esophageal atresia patients with congenital strictures to esophageal atresia patients with anastomotic strictures. And in their hands, they used in a retrospective, so it's reported in a retrospective way, but they use balloons that are huge compared to the balloons that we normally use in an anastomotic stricture. As a result, they have, I don't know how they get to 56%, because 5 in 10 is 50% in my mind, but a huge number of perforations, and still they need to do more dilations as compared to the anastomotic stricture. But having said that, they come to a success percentage of about 90%, which is comparable to the anastomotic stricture. And these data are quite different to the data we knew before, where there is only, and now I really get into a problem, because I think it says something like 27%, but at least a lot less than 90% of patients that have an endoscopic dilation for congenital strictures. Now, I must say that this is congenital strictures overall, so it is esophageal atresia and other patients. It's about 50-50, and they were having balloon dilations and Savary dilations, but they only had a perforation rate of 3%. So 3 versus 50% and 27 versus 90%. So it really depends how much risk you want to take and how much chance you want to take of getting a perforation. The size of the balloons used here was not mentioned, but I think it's only logical that if you have a larger balloon, the risk of getting a perforation is higher. So here again, we need more data to see how we should manage these dilations. So let's move to motility disorders. In esophageal atresia, there are many factors that cause the motility to be abnormal. First of all, there is an anatomical disruption of the myenteric and submucosal plexus at the site of the anastomosis, and it is unclear whether that grows back in a normal way or whether it grows back at all. If you know that the myenteric plexus and the submucosal plexus are essential for orchestrating motility, you will appreciate that motility cannot be normal at this site. There's also data showing that there's inborn hypoplasia of the myenteric plexus with abnormal intraganglionic connections, again leading to abnormal motility. There's abnormal branching of the vagal nerve in some studies, and the vagal nerve is essential in starting the motility patterns that we see in normal patients. And then also, not from a nerve point of view, but from the muscles, there seems to be an abnormal muscularis mucosa, as you can see here. This is normal, and this is abnormal, and this is what we see in esophageal atresia patients. There's more fibrotic tissue in the patients with esophageal atresia, and of course, during the operation, the reconstructive necessary surgery, there is phageal damage, albeit small branches, but there is phageal damage. And also there's inflammation of any kind.
One question. The muscularis mucosa, all the length of
yeah, this is, well, it's hard to say because we only have, we don't have biopsies from the most distal part, and we don't have biopsies from the most proximal part. We always have cells that are just around the anastomosis. So it is not from the entire esophagus. There are studies ongoing with micro CT that I know that are showing the similar things in lower parts of the esophagus. All these factors lead to an abnormal motility, and this is what we see if we do a manometry in a normal patient. You see the upper esophageal sphincter here, lower esophageal sphincter here, and you see a normal pattern of a stripping wave, so of the esophagus pushing the food down. And you don't have to be a motility expert to see that in esophageal atresia patients there is many different patterns, but none of them is really in any way like this one. And I think that most people that do studies in esophageal atresia patients will agree that there is no single patient with esophageal atresia that has a truly normal manometry. If we look further, if we look at not just at the contraction and the peristalsis, but also at the flow, you can use barium swallows for that or high resolution impedance manometry, which correlate well. And you see that the flow is disturbed as a result of this contraction. So it's not just nice pictures, but it also has an effect on how the esophagus empties. If there is a bolus in the esophagus, it will empty less efficaciously. So what can we do with this? It is now recommended to assess this in children with problems. It can be useful to assess the position of the lower esophageal sphincter and to see if there is a hiatus hernia, if you want to test for reflux and reflux disease. It might be predictive to see which patients can develop more severe reflux disease and dysphagia, and it might be helpful in predicting fundoplication outcomes in the future. But it's all predictive studies that show some help. Regretfully, there is no treatment that we can give to these patients that improves motility. There is no evidence for any pharmacological intervention in esophageal atresia patients. And given the underlying pathophysiology that I just showed you, it is unlikely that if you have a completely abnormal structure, that you're going to be able to improve that with motility drugs. So having said that, let's move to inflammation. And I've taken reflux and eosinophilic esophagitis together first, and then I'll go into them separately. Does inflammation lead to disturbed motility? Or in other words, does inflammation lead to feeding problems and dysphagia? Yes, it does. In rats, we know that the more severe you make the esophagitis, the more problems the rat will have with motility. The contraction vigor in the esophagus will go down with more inflammation. We know this, that the peristalsis fails more often with more severe esophagitis in humans. We know that the contraction vigor in esophagitis is less when you have severe esophagitis as compared to none or mild esophagitis. So yes, there is a relation between the severity of inflammation and the motility patterns that we see. If we look into reflux disease, we know, of course, there is a high incidence of reflux disease in esophageal atresia patients, up to 66% in type C and even higher in type A. This can be asymptomatic, and although we are talking about patients with feeding problems, the asymptomatic reflux might not cause feeding problems, but it can cause complications that will lead to feeding problems thereafter. So for example, erosive esophagitis, I just showed you, this will decrease motility and it will give dysphagia and maybe feeding problems. You can get peptic stenosis, you can get potential worsening of the anastomotic stricture, we're not sure, but it could be. And you get worsening of already hampered motility by the reflux. We all prescribe PPI, maybe for the first year, maybe less, but there's little evidence on how to do this. And there is a high prevalence of fundoplications in patients with esophageal atresia because there are limited ways of treating the reflux in any other way. However, I have to give you some concern about the fundoplication. From a pathophysiological standpoint, it is very logical that a patient with problems in the motility and feeding problems, where you're going to do a fundoplication and you're going to give a high pressure zone at the esophagogastric junction, will have more resistance to flow there and will increase the feeding problems. So you might treat the reflux, but you might cause feeding problems as a result. And this is shown in a recent study where we compared patients with esophageal atresia that got a fundoplication. In those patients, 30% have no success from a fundoplication at all, while this is only 8% in patients without esophageal atresia. And even more striking, I think, is that patients with esophageal atresia, none of the patients was completely symptom-free after the operation. So there is a place for fundoplication in patients with esophageal atresia with severe reflux, but we really need to consider when we do this operation and when we make it worse with such an operation. About eosinophilic esophagitis. This is what it looks like endoscopically, and we know from a recent, quite an old study already, that these patients have more motility abnormalities if you do a prolonged monitoring of the manometry as compared to reflux disease and controls. And we also know that patients with esophageal atresia have a very much increased risk of EOE with an odds ratio of 1 in 444, and we don't really know why. There are one of the reasons that might play a role is the PPI use in early infancy, which has an adjusted odds ratio of 6.05 as compared for developing EOE in later life. And many people argued at the beginning when we saw these strange numbers that it must be reflux disease and not EOE, but Usha Krishnan showed that in patients with EA have similar molecular profiling as compared to patients with EOE without EA, meaning that it is not reflux disease that is causing this eosinophilia, but probably the same eosinophilic esophagitis that others have. And these patients might present with feeding problems, dysphagia, albeit mild sometimes, but there is still a reason to treat them, because if you wait, and this is an adult study, but if you wait, the diagnostic delay going up comes with fibrotic features that go up as well. And with fibrotic features, you get more strictures and food infection that are harder to treat than the inflammation itself. So when you wait with the treatment, you probably get more problems in the end. So having said that, I'd like to summarize. There are many causes of feeding problems, of dysphagia and feeding problems in esophageal atresia patients. They can be functional, they can be medical, and they can be in places where you don't expect them as a gastroenterologist. But all of them, I think, should be at least considered, evaluated, and used in the treatment plan that we have for our individual patient with the feeding problem. Thank you very much.
So thank you very much, Michiel. Very nice overview on the numerous causes of feeding difficulties on dysphagia in these patients. Do you have any question from the floor for Nikhil? We have time for several questions, and then we are looking if there are not yet a question from yeah, Ronnie.
Thank you. You just mentioned that in some patients, the fundoplicator may worsening the result. It's a daily question when we have to do the Nissen for this patient with EA. So can you go to recommend a systematic manometry for every discussion for fundoplicator?
Yes, that's a very good question. If you look at the data from adults and patients without esophageal atresia, there is data suggesting that you can use a high-resolution impedance manometry to predict the presence of post-operative prolonged dysphagia. However, we don't have this data yet in esophageal atresia, and that is because the manometry is much more difficult to interpret. It's not as easy as it is in other patients, because all the patients have abnormalities. So we really need to reclassify esophageal atresia patterns and see which patterns may improve the clearance of a bolus. Having said that, I think it's but this is a personal opinion, I think it's worth doing a manometry in each patient, because now I see quite a number of patients coming in with problems afterwards. I do the manometry and I don't know what changed. So I don't know what was pre-existing, and I don't know what was the cause of the fundoplication. And if you see a relatively high IRP, pressure at the esophagogastric junction, is it worth doing a balloon dilation? While that might have been there before the fundoplication already. You only know when you have the preoperative testing. So I prefer to do a preoperative manometry in all patients that are referred for fundoplication.
But to complete that, I think it could be a very nice prospective study to do between ERNICA and ESPGHAN. We already have Thomas Romary had already launched these ideas 2 or 3 years ago. If we prospectively make high-resolution manometry before and see what happened later, within several years, collecting many cases, we could answer this very important question: Is fundoplication harmful or not for motility? That's probably yes, but we are not sure. I think you have
just a question. We learned in the time that many problems are connected to inflammation, because we pediatric surgeons start a lot of time ago to use PPI as prevent the reflux. As any type of study that use anti-inflammatory drugs to prevent this long-term consequence as a basic science or clinical, I don't know.
No, that's a very good question. I'm not aware of any true studies showing that, for example, you use oral budesonide like you do in eosinophilic esophagitis in patients with, for example, recurrent strictures. Or, but I know that there are centers where they do this, and they are not always. Well, they are very keen of telling me how good it works. I don't do it myself as there is no data yet, but it makes sense that inflammation is more than just acid, and that decreasing the inflammation itself, if it's there, might have a better effect than treating the acid.
Only 2 last questions, I'm sorry, but if we have more time at the end, we'll be, but there are 2.
There's Martin Decker from Leipzig, Germany. Thank you for the nice talk. I've got 2 questions. The first one is, in which patients on follow-up do you take biopsies, even in macroscopically normal distal mucosa? Because I always wonder about whether to assess for eosinophilic esophagitis, yes or no. So what is the selection criteria? And the second question I have regarding the manometry, we do not do routine manometry before a fundoplication. So what is your lowest age group? Because these children need to cooperate, right, when they do the manometry, at least in my experience. And the second question is, when we do the impedance study, we usually put the probe while they are sleeping after the esophagoscopy. So when you add a manometry, this would actually be like a second anesthesia in a different type of setting. So how do you handle a patient where you want to do an impedance study plus the manometry?
Okay, the first question is easy. I do biopsies in all patients that I do an endoscopy in. Because we know, especially in younger children, that they can have eosinophilic esophagitis without any macroscopic abnormalities. So especially patients with feeding problems, I do biopsies in all. And even more so in a patient that comes in with esophageal atresia that has newly developed or worsened symptoms of dysphagia or feeding problems, I do an endoscopy with biopsies. Because I want to rule out eosinophilic esophagitis. The second question is, I do it awake. So I do the endoscopy, and another day I do a manometry. I locate the lower esophageal sphincter so that I'm absolutely sure that I position the impedance at the right point, because if there is a hernia, you might be fooled by the radiology. and I do I put in the probe afterwards, and children don't like it, but we've shown that in clinical practice you can do more than 90% of these studies will provide you with a meaningful result.
And regarding the age, lower age?
It doesn't matter. Any age.
So, Julia, very short question, please.
Hi, Julia Brendel from Hanover, Germany. Thank you very much for this very nice presentation. I would like to know, how long do you recommend PPI therapy in general, and how long you do it on average in your clinic? Because there's an ongoing discussion in our hospital about duration, and the recent papers for the last years, they state there's no evidence at all.
No.
So I would very much appreciate your input.
Yeah, I follow but I know there is no input, and I've been very critical about the guidelines that we have at ESPGHAN, but the ESPGHAN guidelines now say 1 year, and so that's what I routinely do. But I think there is very much room for a large international study comparing the different strategies, because I don't believe that you need a year of PPI therapy.
Just to complete here, very short, just to complete here, we did a meta-analysis of all studies published on PPI and different outcome. And the only one we proved by sophisticated analysis of all retrospective, because there are no randomized study at all yet. There was a project in the UK, but I'm not sure it's still started. That's what you always talk about. And the only things we have evidence is that PPI systematically given during the first year of life prevents peptic esophagitis in these children, but no prevention of fundoplication rates, no prevention of anastomotic stenosis. And with Michel and some other people, we are starting, and our USA colleagues, we are thinking about, we have asked our society to revise this recommendation. But to date, it's 1 year of PPI systematically, but probably it will move or be selected to some groups, for example, lung gaps or even things. So very short comment if you want.
Just to comment on the state of the UK study on PPIs, which is there's a randomized control trial which is funded to do, but they can't start yet because the regulator is not happy with the investigational medicinal product. So it's a bit stuck at the moment, but they're still hoping to do it.
Okay, thank you.
There's here that are impacting the care of the child. And then also some strategic work, policy development, service development, supporting change and research. So the picture of the role of a hospital psychologist is quite broad. In terms of what theories underpin this work, developmental theories, of course, one of the key aspects, thinking about what is developmentally appropriate for the child, given the situation, and how illness can be, for example, explained at the level of the child's understanding. In terms of the approaches to interventions, there's a big scale there as well. And this depends quite a lot between different countries, but also within countries there can be variations what kind of approaches are often used. But with younger babies, attachment-based therapies are very common. Acceptance commitment therapy is common in hospital settings, as is family and systemic approaches. But any of those could be used. In terms of evidence-based, because you can imagine the diversity of different health conditions and presentations and family situations, the diversity of the situations impacts the studies as well, that it's very difficult to draw conclusions that what might be the best thing for all, but it's more sort of family and child focused. Each family is unique. Psychoeducation is, as we have heard today, one of the key things when we think about helping parents to cope with child's physical illness. This one will be done in a way that it's appropriate for child's developmental state. And the educational interventions, they incorporate the child's physical symptoms and treatments and the level of development. This can involve also working with the child and family and the whole team. Psychoeducation is important, particularly for parents, because as we heard from the previous talk, the parents are in such a key stage to provide care for their own child, and psychoeducation can really help to empower them to do that. So it can help the parents in their emotional regulation. It can promote parental confidence and skills in managing their child's health condition. Psychological self-help might include psychoeducation to normalize and explain difficult feelings and emotions and to provide guidance on how to develop the more psychological flexibility by accepting the difficult experiences and feeling as they come and developing a more compassionate relationship to difficult experiences. Having a child with health condition is very stressful, but we can learn to build skills to cope with the difficult emotions. Psychological formulation is another very key part of the psychologist's role in pediatrics setting. And here the psychologist with the family aims to explain the development and maintenance of the difficulties at this time and in these situations. It integrates medical, psychological and social difficulties and strengths and indicates a plan for intervention. This can focus on individual child, family or a healthcare team around the child. So we can talk about, for example, team formulations and so on. This is a very excellent interactional model of feeding difficulties, which can be used to understand the children's feeding difficulties in context of EA. Alex will be talking about her research later on, but here we can see how the child factors, the medical factors, following function, feeding experience, mealtime behavior, and then the parent factors, anxiety, isolation, and coping, all interact to develop the feeding-related quality of life and what happens in that actual feeding situation. And then in terms of psychology, can help in terms of the parent anxiety, isolation, and coping, which can then impact the child's feeding experience and mealtime behavior. So quite a lot can be done in these tricky situations. There are lots of different kinds of models for formulations. There can be basic cognitive behavioral therapy formulations where we look at some specific parts of the feeding and what thoughts and feelings and body responses can impact the child's behavior in those situations. There are also more sort of strength-based and contextual formulation where we can look at take a look from further out to see what else is happening here, what are the strengths that we could help to grow. In terms of psychologists helping with feeding difficulties, as we've heard today, feeding is such a key part of the child's early life and forming that healthy mother-child bond. So it's important for both parental and child mental health and for child health. Findings from qualitative studies have shown that parents experience anxiety, related to feeding difficulties, traumatic experiences during feeding, and a sense of loss and sadness. Support, again, was found really important. It can mediate the parental experiences of child's feeding difficulties. And the research sort of concludes that intervention for feeding should be family-centered, addressing parental anxiety, trauma and uncertainty, as well as the child's underlying medical and surgical needs to optimize outcomes. So all of this is really important in the care of the child with feeding difficulties. These recommendations comes from parents of children born with EA, and we can see that in a previous talk they talked about how important that parent education is, and it really came up in this study, which showed that what parents really needed was the information about what to expect when feeding a child born with EA, first aid skills and safe feeding practices, guidance on how to deal with food sticking in child's esophagus, and then guidance on how to recognize and cope with uncomfortable emotions and difficult feelings during feeding. So they are quite simple, but such important steps that every parent should be going home with some level of understanding in these issues. And in order to help with this, at the University of Bath, one of my trainee clinical psychologist, Ella Bailey, has been developing a self-help leaflet for parents of children born with EA. This is aiming to help parents to normalize their sort of difficult feelings, help them with emotional regulation, and promote parental confidence and skills in managing their child's difficulties. So almost like taking a universal approach, that giving every parent the same chance of developing the basic skills. And the way how we've done this is reviewed the previous literature, put together a draft with consultations with patient communities and professionals. And the draft is now ready. And the plan is to evaluate this with healthcare professionals and parents to get their final feedback and then edit and then disseminate through ERNICA and patient charities. I have put the draft here. I'm not going to go through it, but it's for you for your interest to look at that later on. And please do let me know if there's any feedback you want to give on that. But really thinking about how can we help the parents when they go home with their baby to develop those skills to support their baby's feeding better. But thank you very much. Dziękuję.
Thank you very much. Thank you very much. We have time for some question from the audience, or are there some question in the Teams or Zoom links? Perhaps to start, would like to know, post-traumatic stress is a big thing, and feeding is only perhaps one part. What from your experience, is a part of feeding difficulties, dysphagia, failure for a mother or father to feed normally his or her child, compared to the rest, malformation, fear of adverse event, whatever? Do you have an idea of what is the proportion or the weight of feeding in the mental distress, mental charge of families?
Thank you very much for that important question. It does seem that feeding with EA is one of the really key elements in the parents' psychological well-being and stress responses. We have discussed it. There isn't much research, but we have discussed with colleagues about this. And one of the things is that feeding happens every day. It's something you can't avoid. And it's such an important part of the baby mother experience, the bonding and so on. And then if there is always an element of risk involved, there are situations, traumatic situations that the mother has already experienced with their child. It makes that alert state quite constant and can be very, very difficult compared to, for example, if there is another illness requiring surgery. It might not be as part of such a everyday experience as feeding.
And are there any age, neonatal period, teenage or adolescence, where the feeding weight on the mental burden on family and children is more even? And what is it for? I've in mind that parents have fear that their adolescent will not reach the final height, for example, or are not enough strong or not well nourished. So, but for small babies, it's only to avoid aspiration and to be fully fed by mouth and not depending on tubes. So, do you have identified some steps or some to help us to see where are the psychological issue in terms of feeding on growth in the population?
Another very important question. The nature of feeding difficulties and eating difficulties and parents' worries about that would change with the time when the child develops. And it might start with feeding difficulties, but then it might be worries about the child and how they whether they are developing normally and whether they will be bullied at school and so on. There can be lots of different layers coming into it. It's always a tricky decision when to refer to psychology, but if you see that it is distracting the interaction between the mother and the parents and the child, if they seem to be worrying too much, it's always it might be a helpful idea to refer to psychology in that point.
Yeah, it's what I think. There's a lot of insecurities with these parents, and I think the children pick up on that. And there's a lot of interaction, and I think the speech and language therapist, early involvement of them can really help break this circle, because they can show what is normal for a child with esophageal atresia. Because for parents, there's no normal, and that really, I think, could help also prevent all these negative spirals.
That's exactly the point, and that's what came from the research looking at the parent voice, that what they wanted was to see what is normal for their child, and when there's something what they can do to help with the stickies, for example, that they've got those skills when they leave the hospital, and that can then help to empower them to be parents for them.
Yeah, Alex first, and yeah.
Ne marche pas. Il marche. We just did a little bit of research looking at PTSD specifically in feeding, like feeding-related PTSD, and the parents. 37% of the parents reach the threshold for a PTSD diagnosis. So it does look like feeding is a significant contributor, or can be a significant contributor, but clearly not as high as the 60% that was in that other paper. Just a comment.
Yes, the numbers, I think there's quite a lot variability there, and the studies are quite small, so that should be expected. The data has been collected in different ways, but the key message is that the numbers are high.
Yeah, I agree with John that, of course, MDs and SLTs, etc., can do a lot to prevent PTSD or any other psychological or threats for mental health. But do you have any concrete criteria when MDs should refer to a psychologist? Is there a tool or anything they can use to decide on when to ask a psychologist to interfere?
Well, each hospital will have their own different ways. Often, if in the UK, the psychologist would be in the team meetings where each family would be discussed, and then could provide their insights and think that, okay, here I think psychological assessment would be helpful. Because, as you saw in a talk, because the causes of psychological difficulties in parents and the poorer outcomes are so multifaceted, there are so many factors contributing to each family's well-being that it would be recommended, I think, that it would be a full psychological assessment of the family rather than just one instrument that would be used in these cases.
Short question maybe. So you focus on feeding difficulties and anxiety about that, but did you also look at respiratory complications, for instance, or other systems involved?
In one of the studies that was again mentioned as the one of the child-related factors for the parents' poorer psychological outcomes. But the feeding difficulties is one that most consistently comes up as a child-related factor.
So last question, yeah.
Jens Dingemann, Hannover, Germany. Woko, many thanks for your nice presentation. Comment rather than a question. This is also important in and after transition to adult medicine. So what we do, and Andre, that gives you maybe a quick answer to your question. What we do in our transition clinic is that we use WHO5 for depression, and it showed as a screening tool for every patient. And then we refer to psychology underneath a certain score in that screening tool. And this is around 20-25% of adults in our transition clinic.
Okay. So thank you. Thank you very much. We have to move. Thank you again, Woko, for this nice talk. So we have to move to the speech therapist, and I'm happy to welcome Alex Stewart from Great Ormond Street. And I understand she speaks French fluently, and she could do the talk in French.
Presque parfait.
And so the talk is how to assess the feeding problem and swallowing score, how to assess these quite difficult things. Thank you, Alex.
Thank you so much. Thank you for the invitation. It's lovely to be here. So yeah, I'm tasked with trying to think about how we go about assessing these feeding difficulties. I am a speech and language therapist, and actually that in the UK is a kind of professional where I've been working with feeding and swallowing problems for 20 years, even though I trained as a speech and language therapist. It's kind of a subspecialty of speech therapy, which I don't think exists in a similar way in lots of other countries. So I am called a speech therapist, but please don't ask me anything about speech because I have absolutely no idea. Yeah. So I am going to follow on from where Michiel left off and think about defining these feeding problems. And I've used this framework that was described in 2019 by Godet and colleagues, where they're looking at impaired oral intake that's not age appropriate for at least 2 weeks and associated with one of these 4 elements. So they describe them as medical, nutritional, feeding skill, or psychosocial. So just summarizing this, the medical thing they describe as a cardiorespiratory compromise during oral feeding. So it could be coughing, changes in breathing, or it could be aspiration or recurrent aspiration pneumonia. Nutritional, they describe malnutrition or deficiency in nutrient deficiency as a result of reduced range of foods that the child is eating, and a reliance on enteral feeds or oral supplements. A feeding skill, they're thinking about the need for a modified diet, use of different feeding strategies. So the child may or may not have a dysphagia. There may be numerous different reasons for those changes to feeding a reduced range of foods or only eating pureed foods. And then finally thinking about the psychosocial element, which we've already heard about really nicely from Roko. But this extends beyond just that parent and child interaction, but it could be around the child's behavior at mealtime. So any sort of these food refusal, those sorts of things will come into this psychosocial domain of feeding problems. I'm not going to talk about nutritional aspects at all in this talk because I think it's been covered by others. But just to say that I'm describing here a pediatric feeding disorder, but esophageal atresia is not only a pediatric disease, it is adult. And so this definition, although defined for children, actually works if we look at it a little bit sideways for adults as well. And it's based on the WHO ICF classifications, so we can think about it from an impairment, a function, and a participation perspective. So although this is children, I'd like to extend that to thinking about all people with esophageal atresia. We looked at how these characteristics in esophageal atresia might fit with these feeding problems. And we've recently done a systematic review looking at all the evidence and pulling it all together and trying to do a meta-proportional analysis. So when we're thinking about cardiorespiratory or aspiration-related difficulties in this population, we can see that there's a 0.22 or 22%. And when we pooled the evidence across all ages, I'm going to say, this is evidence from adult studies and pediatric studies pooled. And the numbers are 95% confidence intervals in brackets. So around 22% are reporting coughing when eating. Around 25% had aspiration on a video fluoroscopy. I'm going to talk a little bit more about that later on. But we can see that there is certainly evidence for medical type dysphagia in this population. When we're thinking about the need for texture modification, so often this is around not being able to manage particular types of food, particularly very chewy foods. Hard foods like meat is particularly problematic, bread. So around 30% of people are reporting those sorts of problems. Almost 50% are needing to use other strategies to help food go down. 50% around drinking water or eating more slowly, prolonged meal times, all these types of modifications that people are making. Now, this doesn't necessarily mean that they have a feeding problem, but these are adaptations that people with esophageal atresia are making. They may or may not need further intervention. When it comes to the evidence for psychosocial impacts, there is a lot less there. But this has been researched a lot less. There's only one study that reports specifically on adults, and they're saying that 10% avoid eating with their friends. And when we pool the evidence looking at children with more challenging mealtime behaviors, food refusal, needing a lot of distraction at mealtimes, parents are reporting that in around 25%. And this increased parental anxiety that we've heard about pooled to around 35%. So significant numbers, certainly plenty of evidence to say that feeding problems need looking at. So how do we go about assessing them? That's really what I'm here to talk about. So we can start off by looking at symptom report, and there are numerous tools out there that, from the patient or the parent perspective, will screen for swallowing problems. This is one of them, the PEDI-10. It is very quick and easy to use. Parents can complete it in minutes. You can use it across all ages, which is very useful. There's multiple language translations, and it gives you a cutoff. It gives you a cutoff score. So you add up the total numbers. If the score is 4 or more, it suggests that there is some sort of swallow dysfunction that requires further assessment. And it just about covers all 4 of our aspects of a feeding disorder, all 4 of those medical, nutritional, feeding skill, and psychosocial domains. Another tool that's focused a little bit more on feeding behaviours is the Montreal Children's Hospital Feeding Scale. This has been used in fact, PEDI-10 and this tool have both been used in esophageal atresia before in research. Again, pretty quick and easy to use. It's a Canadian tool, so it's French and English versions. And we can achieve a score of mild, moderate, or severe feeding problems. Again, it's a nice screening tool, potentially a tool that might be useful in a clinic, in a gastroenterology clinic or a surgical clinic, to then signpost towards further assessment. And then just an adult tool. So this is another self-report feeding scale that has been widely used in adults in dysphagia, not specifically in OA, but widely in head and neck and neurology. It has multiple language translations. It does look at impairment function, a little bit about participation, and there is now an electronic version. Thanks to Hira Mari's team, looking at using it with Swallow Gateway high resolution manometry. They've developed a tool that is now available electronically. So there are numerous other tools, but those are some of the available ones. But symptom report is going to take us so far. Then actually the next step is looking at a true swallow, a feeding observation. So whereby we now want to know a little bit more detail about what the child is managing. So much like Anne-Maria was talking about, we need to know about whether the child is even ready to feed. Are they alert enough? Are they showing us signs of hunger? We need to know about their respiration. Clearly a child who's got a high respiratory rate or big effort because of tracheomalacia is not going to be able to feed effectively. We want to look at oromotor function. Generally, I don't bother to ask a child to stick out their tongue because it doesn't tell me that much, but a functional oromotor assessment is going to be really useful, looking at tone, looking at symmetry, looking at involuntary movements. Maybe not quite so common in esophageal atresia, but certainly good to rule out when thinking about differentials. Non-nutritive sucking just is sucking that's not related to eating and drinking, so on a pacifier, a dummy, or a mum's finger, tells us a certain amount about how the child is managing the coordination of their oral movements. And we're thinking about saliva control, and we're thinking about the child's voice and cry. So it tells you it's a screening tool for vocal cord palsy, which can impact on swallow function. And then we're going to actually observe the child eating and drinking. We try and keep this in a naturalistic environment, and the child is going to be fed by a familiar parent, or if they're breastfed, they're going to be breastfed. If they're bottle feeding, they use their normal bottle. They have familiar foods. And we divide it into the oral phase, so we're looking at how the food is getting into the mouth, how the child is preparing that. Are they able to contain it in a nice cohesive ball? Are they able to push it backwards in a controlled manner? And these things we can observe. We can look at them and we can look for potential abnormalities. And we can do this by looking for signs of arrhythmic sucking, poor lip closure, food falling out the front of their mouth, drink dribbling down. And we can look and see if the mouth is cleared of food after they've fed. all of these things that are observable by just looking. And then the food is moved back and hopefully a swallow is initiated. Central pattern generated movement, whereby we get pharyngeal stripping, we get relaxation and opening of the upper esophageal sphincter. Now, this part is very difficult to see just from observation. We can see, oh, my pointer's stopped working. Oh, there we go, there we go. This bit we can see basically nothing just from looking on the outside. I can infer, but I really can tell very little about what is happening as the food is moved from the back of the mouth down through the upper esophageal sphincter. And we're looking for airway closure. Now, I can't see this just from looking on the outside, but what I can do is look for signs of potential abnormality, coughing, changes in airway noise, respiratory changes, prolonged swallow apnea in neonates, in infants even. So I can get an idea about what is happening, and I can certainly start to differentiate and say, oh, this definitely looks not like the child has any sort of oral phase difficulty, chewing is normal, but there are still signs of feeding problems. So we can get some idea from this history, from symptom report, from feeding observations about medical and feeding skill. But in esophageal atresia, as Michiel has already talked about, what is this caused by? Actually, there are so many overlapping symptoms: coughing, gagging, food refusal. It can be caused by any one of these difficulties in this population. So in order for us to differentiate between the underlying cause so that we can get appropriate treatment, modify the modifiable, and then actually dig down to what is the true underlying cause of what is going on, we need some instrumental evaluations. I'm not going to go through all these, but what I am going to do is talk briefly about some that a speech and language therapist, certainly in the UK, might use. Oh, is the other video? The other videos? Oh, there we go. So the one on your left is a video fluoroscopy, radiological examination of swallowing. It's a great overview of oral, of pharyngeal, and potentially of esophageal function. We can see airway invasion, we can see post-bolus residue. It gives us a lot of information about globally what's happening with swallowing. But what it doesn't do is highlight very well why that is happening. So the middle investigation, the FEES and endoscopic evaluation of swallowing, is excellent for visualizing the larynx. And we can see very clearly whether there's any problems with vocal cord function, with airway closure. It gives us an ability to assess secretion management, which we can't do on video fluoroscopy. But actually, if you, hold up. As the child actually swallows, you get complete whiteout. So it's not great for during the swallow, but it's great for before and after the swallow. And then finally, have esophageal manometry and pharyngeal manometry. So this is our kind of newest modality for assessing feeding. And somebody was asking earlier about how young you can assess using pharyngeal and esophageal manometry. Well, we've been doing it in babies 2 months old. And although it is still, from a pharyngeal perspective, still relatively experimental, and we don't have good normative data, actually it gives us fantastic understanding of what's happening at the upper esophageal sphincter, which we don't get from any of the other investigations. So 3 very different modalities giving us all different and valuable information. So we've sort of talked about impairment and we've talked about how to assess function, but we haven't really talked about psychosocial. So as Burko has already said, this eating and drinking is so much more than just swallowing. It's celebratory. It's interactional. It's a bonding experience. And so when it goes wrong, it can also be extremely isolating and anxiety provoking. And just a couple of quotes from research very similar to what Vorko has been doing, that the parents saying, every feed I prepare for the worst. I'm on edge and I hold my breath. I don't take my eyes off him for a second. And this isn't just at the moment, the point of starting feeding. This is prolonged, this is pervasive. This happens because feeding is a developmental process. It starts from breastfeeding or bottle feeding in those early days, but it's a constantly changing landscape within that, certainly the first year or 2 years of life. So the parents are having to support their family through new developments. They crack one thing and then it's like, oh, but now they've got to start solids. And the process starts all over again. And then they say, oh, but he's doing so well with puree, but now you've got to try and give him an apple or something to chew. And so this process continues for years. And without good support, without the stuff that's going on with in Sweden, parents do feel extremely isolated and fighting to do the best that they can every day. You've already seen this. So I very much advocate for this holistic, dynamic, dyadic assessment of parent and child. So these are some tools that you might think about using as screening tools for feeding-related quality of life. Their surveys, the first two are parent-reported, and they will demonstrate excessively high levels of worry and anxiety and quality of life impact specifically for feeding. They're not anxiety or depression or PTSD scales, but they are screening tools to help guide those who might need additional support, be that from speech and language therapy, psychology, nursing. Those two, the feeding impact scales and feeding swallow impact survey, are very similar tools. And then thinking about our adults who also may have significant impacts for feeding related quality of life, there are numerous tools, but the SwalQual is an example of one, which could be as well guided to help, used to help guide those who are going to need further support. And then just briefly about when to assess. As far as I'm aware, there aren't guidelines available at the moment that suggest when to carry out assessments for esophageal atresia patients for feeding. But I feel that pre-repair for long gaps is obviously of vital importance. Promoting sham feeding, or if the baby's not able to sham feed, positive non-nutritive feeding experiences in an effort to reduce longer term impacts. And then an assessment, certainly post-repair, whilst they're establishing feeding, and then at those key developmental milestones, feeding milestones of solids and then more chewable foods, and then maybe a symptom-led approach is best. I think one thing to remember is that symptoms do not always align with or dysphagia doesn't always align with symptoms, or how bothersome or how burdensome it is for an individual. So I think it's quite difficult to put on clear, we need to have assessments at 14 years old because one child is going to have relatively normal function but a large impact, and another child is going to have grossly abnormal function, but it's actually adapted and accepted really quite nicely. And so they're going to need less input. So I think if we think of it as a holistic assessment and that we value the psychosocial impact as much as we do the functional or the medical, then we get to the right outcome. Just a quick word about Ocelot. They're developing a core outcome set, of which feeding and swallowing will be part of it. And it is complex and multifactorial, and so, as has been said before, it's definitely a team effort. I'm going to finish with an interesting fact, actually. owls can't drink because their trachea, their glottis is in their tongue. So they all aspirate. There we go. Interesting fact.
Thank you very much. Very complementary to the previous one and very interesting view. Do you have any question, comments on the floor? Yeah, Stefan.
Yeah, brilliant talk, and I think there's definite need to know when to look at the swallowing function, feeding functions, and the different, like one of the last slides you just showed. But should there be like a real guideline? And if we do studies on outcome of our treatment, that we should also include specific swallowing scores or feeding scores standards. If you want to publish your data, then this should be included as part of your follow-up.
Yeah, that's what the Ocelot team are trying to pull together, and I think that the tools that I've presented will be the ones probably that will be recommended. I don't know about that, but yeah, I'm have been vaguely a part of the team.
Are there a really specific pattern in terms of speech therapist, hypersensitivity, nausea, and so on, skin sensitivity in EA patient compared to other oral aversion or oral difficulty patients? I don't believe, but I would like to have your...
I think it's an interesting question, and actually when we're looking at characterizing the nature of the feeding and swallowing problems, actually there isn't there are different, like motility patterns clearly are different, specific, and there are specific, but in terms of the more functional, I guess, if we're, or behavioral type problems, actually they're quite similar, and I think the reflux question is quite an interesting question, as how does reflux interact with the other feeding problems, and what drives, is it the reflux? Because we know that in children without OA, reflux can be an influencing factor on hypersensitivity, on food refusal, on texture specificity, and I don't think we know within an OA population how much that is driving these presentations, because I find it quite interesting. You know, all children have dysmotility, but some of them seem to cope extremely well and others don't. And what is it? What are the other factors that then make, is it, and I don't believe it's necessarily the number of strictures you have, or necessarily that you are, you know, you're complicated post-op course, or that you're premature, or, but for me, tracheomalacia is a big thing. I think that really has a huge influence on early feeding ability and feeding skill, possibly reflux. Yeah.
Yeah, thank you for a very nice talk. In addition to what you were just suggesting, would you think it would be helpful if you do an evaluation from a speech pathology standpoint before a patient is sent home, either using one of your techniques that you showed, and what would it help to treat, or how to introduce feeds?
I think every child, whether it's from a speech and language therapist or a specialist nurse or an occupational therapist or doctor, or somebody, should have as a bare minimum a clinical, a feeding observation to assess for bolus transit, to assess for swallow initiation, to assess for these early signs of potential food aversion, because a baby can be sent home fully orally feeding, and actually the quality of that feed is poor, and we set them up for then later on feeding aversion. But if you have early intervention, and actually we're picking up, certainly in the UK it would be from a speech and language therapist, we are able to initiate earlier identification of potential problems, then you prevent the later larger scale problems. So actually simple strategies like cue-based feeding. So actually the parents are learning when their child is hungry and how to respond to those hunger cues is the most effective strategy that we have for preventing things like oral aversion, food refusal, poor weight gain, all of these things. And actually you can get a child home, but with poor quality feeding. And that is the benefit. And I think then you can say, I don't think every child necessarily needs a video fluoroscopy or a FEES or pharyngeal manometry, but what we do want is to make sure that they've all been screened, that we've got earlier intervention, that we're trying to pick up those problems early. And then I think actually the point at which it's very useful in this population to have some sort of swallow assessment is pre-weaning, because we then get more problems that weren't there previously with liquids. As soon as they start solids, then we have a problem. And I think at that point, it's when the parents really need close hand-holding. Not hand-holding, they need support. They need somebody to say, this is normal, this is good, this is not normal, we need to investigate.
Thank you for a brilliant talk. I just wanted to know, when would you think that early assessment would be appropriate? At like 3 months of time, 3 months of age, or when you said you do this on everyone as a baseline, when would be an appropriate time?
As a baseline, before, as soon as they're starting to establish oral feeding. So at the point of starting feeding post-repair.
Okay, so already like before going home, like one week of age or 2 weeks of age.
Exactly.
At that early stage.
Exactly.
So before we send them home, we're very proud and we're bragging that they're eating fully when we send them home after 2 weeks. But then you can tell us at that point whether they do it well or not.
Quality, not quantity. But no, I think that early stage.
That you should do that so early, because obviously we have the involvement of speech and language at the follow-ups and at the later stages. But you should be involved very early.
That's what we would advocate. The earlier we can get involved, the easier it is to prevent the longer-term, more complex problems.
So in our hospital, it's standard. It's also to know where to go if you have a problem.
Yeah.
And so you can introduce and be there, witness the first feeds, but then also, if they have questions, they know how to reach you and how to find you, I guess.
Yeah.
Okay, we are just on time. Thank you again, Alex, and thank you again. I will follow up with nutritional support in a child with esophageal atresia, and I would try also to bring the voice of the dietitian. I prepared this talk with my dietitian, but she couldn't attend the meeting, but I'm not. Yeah. So how to support, and Audrey Vomelengem is our dietitian helping me to prepare this talk. Okay. Okay. So this one. Okay, as already mentioned, nutritional support is at any age because feeding disorder and dysphagia start very early. And sorry, here is a timeline of the life, starting in fetal life, and you know we have very nice MRI, dynamic MRI, showing that a child in utero with esophageal atresia is vomiting and already has dysphagia, big dysphagia at that time. Of course, at birth, because of many reasons, the pain, intubation, aspiration, in French, so it was easy for us to use, but also in English, and it's very easy to use, but Alex spoke about this scale. Looking at in many French centers, almost 150 children aged 1 to 3 years with esophageal atresia. As you can see, only 60% have really normal feeding. Many of them need some support, nutritional supports, and almost 10% had no food autonomy, meaning that at that age they are 100% fed by a tube, a nasogastric tube or gastrostomy. And feeding disorders were almost, according to the scale, it was almost 42% of these children. So it's very, very frequent. So the first question, and I will go quite fast because it's not at all specific for esophageal atresia patients, but how to assess a nutritional status. Of course, as clinician and clinical setting, anthropometrics with the weight, height, and different BMI or ratio or Z-score are available with WHO curves. Is mandatory to have this measured at any age during the follow-up to have a dynamic vision of what happens. Upper arm circumference is easy also to use, and it's easy also to remain that for any children, the ratio on the upper arm circumference on head circumference should be better than 1.35, and that's in children less than 4 years, and it's very easy to do, and it gives you information about fat-free mass and undernutrition, very, very nice anthropometric measurements. Of course, you can use body composition, more sophisticated methods. Skin folds is available, but it's a long, you need to be trained on that. And there are many other bioimpedance, body X-ray and so on, but they are not used at all in routine. Biological parameters for diagnostic of undernutrition are of little value for a child. It's only to detect some micronutrient deficiency, iron, vitamin D, for example. And of course, to assess nutritional status in this an esophageal atresia patients, you need questionnaire or 24 hours recall by a dedicated dietitians to have exactly what are the calories, what are the rate of carbohydrates, lipids, minerals, vitamin, and so on to help the nutritional support. You need to know where are you coming from. There are indeed many risk factors identified for undernutrition in esophageal atresia patients. The first one, very important, is intrauterine growth retardation and prematurity, which are an additional risk factor to be still undernourished after the operation and care. Cardiac malformation appear in many studies are an independent factors associated with undernutrition in esophageal atresia patient. Of course, long gap, we heard about that when you have tension, when you have to delay esophageal anastomosis. Of course, this is a very high risk, and also for esophageal replacement, there are nice studies showing, for example, that adolescents and adults with a coloplasty are undernourished in 1/3 of them, and smaller than normal adult population. And also other associated malformation, microgastria and gastric emptying delay, which as already mentioned is under-recognized and is a cause of vomiting and severe gastroesophageal reflux or failure to feed the child or to use gastrostomy or nasogastric tube. And also I want to focus on this slide showing our experience longitudinal studies in a cohort of 100 adolescents we followed in Lille, and showing that wasting and stunting is, of course, as expected, quite high in the first year of life. But at the time of adolescence, I want to give you a warning, because at that time they need more energy to have the puberty and more physical activity. And this is probably another high risk, a high time of risk for undernutrition, and we should keep on following on nutritional status of this children, and nutritional support is sometimes required during adolescence. So which type of nutritional support? This is the same as for any pediatric disease. And I want to remind that if the gut works, use it, as it's very, very famous word. So So use the gut, and most of the time, gut is working in esophageal atresia patients. So when you need a nutritional support, first is to enrich food, normal food, then to move to oral supplements, and then to enteral nutrition, and in very rare case, parenteral nutrition is required for these children. And in one of the cases we will present later in the meeting, we will show that sometimes parenteral nutrition is safe-living option and good option for a bridge and improving or waiting for a better time for a child. So if I start with starting feeding, of course, and it has been already addressed, we need to involve parents, healthcare providers, nurse, whatever, a psychologist or a speech therapist should be present at the first oral food trial, and then regularly to reassure parents, to give some advice, to train the families. And adaptation are needed very frequently in terms of different of quantity, feeding methods, stimulation of suckling, and so on, depending on the child. We have to adapt the diet, so it's in my hospital, it's a discussion between doctors, dietitians, and speech therapists according to what are the oral behavior of the child. So you can change viscosities, textures, temperatures, the size portion. Sometimes you give some small portions in a child, for example, with a severe cardiac malformation, who make a very high energy expenses only to suckle. Change the taste of food or liquid. Sometimes we made the liquid thicker or smoother, or chopping or mashing solid food. So you have to adapt to any child and to make a really personalized feeding, and to try to provide additional sensory input to help swallowing, so to be in a good atmosphere, to have no noise and so on, to be in a good, not in the middle of your words, and be quiet. So when you need to enrich milk, of course, breast milk is a preferred method and can be enriched, especially for premature or catch-up growth children. Infant formula can be enriched quite easily with fat and carbohydrates. All the formula available on the market is 0.7 kilocalories per 1 ml. And it's quite easy for a dietitian, and we are using that very frequently to increase the energy density of a milk formula to 1 kilcal per ml, sometimes 1.1, sometimes 1.2. There are different ways to enrich, so the dietitian know how to deal with that. Sometimes is increasing the ratio of power and water. Sometimes is adding some sugar or some lipids in the milk. And of course, maltose dextrine, which is very popular in France, to enrich diets, can be substituted with natural infant cereal if needed, because cereals are carbohydrates. So I have again a problem. Okay. So what type of lipids? You can use vegetable oils, mixed of 4 oils or rapeseed oils. We can use medium chain triglyceride oils. It's only when the gut is malabsorption of lipids, so it's not usually, it's not the most frequent. One of the advantage of MCT, sorry, is to be completely neutral in taste, so children don't feel that there have been oils in the formula. Since the other oils could have a taste, which is not very good for some children. And you can also, we are French, you can put butter in the food, of course, if there are no allergy to cow milk protein. So you can use natural food to enrich things. This is the experience of our speech therapist in Lille, where she followed, you see 100 children at different age, starting at 3 months until 6 years of age. And she looked at the numbers, so it was all the children with esophageal atresia. As you can see, at 6 years of age, the vast majority were fully oral fed, and it was 3 out of 4 at the beginning because of the surgical and circling difficulties and so on. As mentioned, and this is something we all know, is at 3 months of age, all the children receive liquids, so no dysphagia, no problems for feeding, even if there is a big stenosis of the esophagus. And once you start solid food in the diet, you see that dysphagia is more frequent. I believe it's not a new dysphagia. It's only because dysphagia you can make the diagnosis because you enter some solid food. That's why most of the parents delay introduction on solid food, and we are trying to explain that we have to introduce them. And it's quite frequent in our experience that an infant of 1 year of a child of 1 year of age still receive only liquids and is not solid food because parents are a fear of any blockage or vomiting and so on. So in a older child, you can enrich food. It's very easy. It's had fats and carbohydrates in small quantity in every meals. You can use butter, rapeseed, sunflower oil, maltodextrin, mashed potato flakes, and also it's very easy, for example, to use full fat milk for drinking and not low fat products in a child. And it's an easy way to bring more calories in the same volume and with the same taste. I'm not very positive about oral nutrition supplements. So there have been, to be completely honest, there have been a meta-analysis, a systematic review and meta-analysis published 3 years ago. This is the only one showing a positive effect, but when you look at the list of authors, all of them were employees of a food company who make on the markets of some food supplements. So I have a big caution about this paper. When you look more in detail on the paper, there are very weak evidence of efficacy, and the major risk is a substitution, meaning that if you give a supplement, if you give a bottle of whatever, milk, of soup or whatever, the dessert of the next dinner will be reduced because the child so he has a new dessert, and it's quite expensive. In France, it's reimbursed. So we pay for that, and the child don't eat his yogurt or fruits. And at the end, the calories is not so much increased. So if we give some oral nutrition supplement, what is very important is to give it away from meals. It's not a substitution. It's, for example, at 8 p.m. after the dinner, before going to bed, drink one or eat one supplement. It's more calorie. But if you put during the day in the meals, the risk is that a substitution and nothing more happens. It's a very personal view. So we need some leaflets, some information, some training of the family. So I'm sorry in French, but this is a booklet we give to all the child leaving our wards, and there are different topics addressed, and one is about dietetics here, and here is some very simple information for family, how to prepare meals, how to give meals rich in calories and so on, to train and explain and the family for that. So when all things fails, we have to move on to enteral nutrition. Enteral nutrition is working well. There have been very major advances in enteral nutrition since 3 or 4 decades with a PEG tube. So endoscopic is now very easy. You can have a button. You have a home enteral nutrition support service now available quite everywhere. And you have also nice products, well balanced with all the energy, micronutrient, vitamins needed for a child at any age, because we have different type of products. So we can use different type of tube for feeding a child with esophageal atresia. We don't like nasogastric tube for a long time. As you know, many consensus or recommendation advise to move to gastrostomy when the dependence or need of enteral nutrition is more than 2 months. So for esophageal atresia children requiring enteral nutrition, sometimes it's more than 2 months, and so we can move to gastrostomy, either surgical, radiological, endoscopic, whatever. When you have microgastria, gastric emptying delay, aspiration, severe GERD, gastrojejunostomy or surgical jejunostomy or any kind of jejunostomy can be used to avoid aspiration and vomiting and reflux. And you can use balloon or non-balloon buttons. So, and I just mentioned the update position paper on PEG, which were published 3 years ago. You can use different type of products. So the most standard polymeric products, including fibers, are whole 1 kilocalories per ml. It's better to give fibers, of course, because you need fibers in your natural food. And you can use some high energy needs or real food ingredients, which is now more and more popular in families who want, even if tube-fed children, to give natural food. So there are products from the industry based on more natural food, and there are also some family using their home meals and mixing, and it required a very strict follow-up by a dietitian because there is a risk of mistake or undernutrition or whatever. And so, of course, you have to monitor growth and to adapt energy and avoid overfeeding in some of these children. Here is our experience of some of these children with esophagostomy here. This child was feeding as he wants with no tube because he had a pharyngostoma, and he was fed directly because it was a long gap waiting for natural growth and secondary anastomosis. Just one topic on the weaning. When you start enteral feeding, everybody is happy, the child is growing well. Family is less fear with the feeding, everything is quite comfortable, and sometimes it's difficult to wean the child from enteral nutrition. They are used, they copy with the tube is there from birth, so they are used to have enteral nutrition, and at the end you have to wean. So just to mention that there have been recently a consensus or recommendation about the way of weaning, and we have to think about weaning as soon as we start enteral nutrition to prevent the long-term dependency on enteral nutrition. Parenteral nutrition, I look at the PubMed and I was not able to find just one paper coming from 1970s about 3 cases of long gap receiving parenteral nutrition. So, but there are very few data published on that. It's expensive. It's many complications. It's high resource requirements, but it can be life-saving in a highly selected case where inability to use GI tract or in several cases with poor respiratory condition, aspiration, recurrent fistula, as we will present a case later on. So my take-home message are nutritional support is frequently needed. Infancy and adolescence are critical period for them. When food adaptation and enrichment failed, enteral nutrition is often needed. Weaning is possible and should be anticipated. It's, of course, a multidisciplinary approach, and we have to continue the follow-up through childhood because nutritional problems don't stop after transition. They are still there. So thank you for your attention, and if I have some time, I'm ready for answering questions. So we have time for one or two questions. Yeah, Stefan.
Thank you very much also for your colleague who is now here. Well presented, I guess. I'm very curious about we go to blended diet and home diets, and actually we never worry too much about what parents put in there, because it would be the normal food they would have given their child without the disease. So, and you said you were worried about what they put in there.
There are three issues about homemade blended diets. The first is unbalance in terms of energy or micronutrients, especially fiber or vitamins.
But wouldn't that also be in any normal child, whatever the parents give their child?
Yeah, but this is balanced one day to another one. They don't put exactly the same feed because they look in the internet, they look at some, they cannot use every meals because they have to mix it. Yeah. So it's not really what the child, they pick potatoes and they pick some meals, and the child don't control what he will eat or not. It's the parents who put the mixture, so you don't never know. So that's first concern. The second is the blockage of the tube. You need really to have a good machine to have a smooth, because there have been a report of blockage, of change of the tube. And the third one is it's okay if you do bolus, but if you use continual nocturne enteral nutrition, there are major risk of contamination, bacterial overgrowth in the feed. So if it's given at bolus just as on half an hour, 1 hour, no problem. But if it's used in jejunal continuous, you have a major risk after 3 hours at the temperature of the room to have bacterial overgrowth on that. So that's the two. Yeah.
And then maybe another question on this. You said that gastrostomy should be considered after if you need enteral feeding
for more than 2 months.
For more than 2 months, but there are many complications also about the gastrostomy, also about gastric motility, and it also has some disadvantages.
This is a general recommendation. Yeah. Of course, you have to adapt to each cases or each single cases. But when you look at the ENT problems, over salivations, some ulcerations, some abnormal oral feeding, when you have a tube every time in your mouth, on your nose, it's more difficult to eat or to have a normal eating. Yeah. And compared to very low risk of gastrostomy, very low risk, there are big series on PEG now, more than PEG than surgical, but the risk are very low, quite no mortality, sometimes one pneumonia, and no infection, no more infection with the push technique. So
yeah, but then it's a balance, of course. It's of Atresia patient. Of course, there's quite a lot of morbidity also on the gastrostomy.
Yeah, of course, okay, of course. And microgastra, for example, is one problem, and so.
I just wanted to add for the blended diet, a lot of parents add water to the food, and then it's very low calories that you give them.
Okay. Thank you, Saskia. So she helped me. That's very good. Good friends. I think we are on time, and so Saskia, it's your turn. So Saskia is a pediatric gastroenterologist working in Ghent in the pediatric gastroenterology department, and she will talk. I'm very happy to see you, Saskia, and she will talk about growth. Now we are moving on the result of feeding. What is the growth of the children? Thank you, Saskia.
Good afternoon. Thank you, Frederick, for inviting me. Thank you for the organizing committee to have me here to come and talk on growth and nutrition in EA adolescents. I already saw there's some overlap with Frederick, so maybe we can move on a little quicker then. So in 2016, the EA guidelines stated that prevention of feeding difficulties and treating feeding difficulties is very important. And we should do this in an intensive way and as early as possible. This was what Frederick already told. We all know that there's many risks to develop malnutrition in children. And this has also been discussed already, that there's a lot of symptoms, gastrointestinal symptoms, that can lead to a poor nutrition, a poor growth. But probably having a malnutrition will also have more or worsening of the symptoms on themselves. And these will all lead to social difficulties, but also a health-related lower quality of life, a lower emotional score and physical health. And above all this, EA patients will often have a lot of respiratory infections, a lot of respiratory problems that will have an effect on both symptoms, nutritional status, and their quality of life. So what do we know about growth in adolescence? This is a review of 2016 that mentioned some studies. As you can see, these are some older studies. These are all single-center studies, and they are about 20 to 160 patients. For example, 10% has an acute malnutrition. Here you can see 9% has acute malnutrition. But on the other hand, 16% of these patients were obese. So a quarter of the patients have a poor nutrition status. On the other hand, we see that there's also a 6% of adolescents and adults who have chronic malnutrition. And here in this group, we can see that this is up to 20%, but these were for children with a mean age of 9 years. And when they looked specifically at the older group, they saw that the chronic malnutrition was less. So probably there was this kind of catch-up growth between younger children and adolescents. There are some more recent studies that look on growth, and these are studies that are more specific for adolescents alone. And this latest one is a systematic review who looked at 830 EA patients. Again, you can see that there's a quarter of patients with low BMI. We see here a third of them have a short height, so chronic malnutrition. Half of them have a low BMI. In this study, they found that 7 to 8% had stunting, but when they looked at target height and parental height, the stunting was a bit less. And then here again, we see that when we look at the systematic review, that 1 in 5 is underweight and 6% has a reduced height. When we try to predict what is giving a poor outcome, you see lots of different things, and it's not clear that there's just one thing that is associated with poor growth. So is it interesting to know what the correlations are with poor growth? Of course, because then you know what you have to tackle to have a normal growth or a normal nutritional status. But as you can see, there are studies that say that there's a negative association, but then again, in other studies, we found that there's no association. So looking at all these different correlations or predictors, I think that the question mark is still there, and we do not know what will be the factor for having a poor growth or a malnutrition status. Are there studies on nutrition in adolescents? When looking, I could find globally 3 studies on nutrition and only 1 on adolescents. So in 2017, 75 children up to 17 years were reviewed 3/4 by a dietitian or a speech therapist, and half of them needed a texture modification, as already been discussed. But they could find that so there was especially a less age-appropriate texture of the feedings, but this improved after 5 years of age. The study in 2020 looked specifically at 86 EA adolescents. Only a quarter of them was reviewed by a dietitian. And when looking at micronutrients, they found especially a vitamin D deficiency and an iron deficiency, but this was completely comparable to healthy people. So, but their energy intake, even in adolescence, was still lower than the age-appropriate recommendations. On the other hand, we do not know what their physical activity was in these children. The study in 2021 looked at 21 children up to 17 years of age, and they compared them to 21 healthy controls. They found that there was a similar energy intake, but there was a very high proportion of fats in the intake of EI children. So is there a spontaneous improvement? I put it in a question mark because I do not think that there's a spontaneous improvement. I think it's more that the adolescents have compensatory eating behaviors. We already discussed about that, so it's not really an improvement, but we see that weight and height is improving when we look from infancy to puberty. This is what we already saw. As you can see, globally, there are less adolescents with a chronic and an acute malnutrition when we compare them to infants. So maybe our puberty is an additional window for opportunity, and I guess it is because we all know that both the musculoskeletal and the gastrointestinal symptom have two important timings of two important times of exponential growth, and that is both infancy and puberty. I tried to find if there were any interventional studies looking at intervention during puberty and then looking if there's a better outcome, but I could not find any. What's important when we talk about GROW and chronic malnutrition, that is that we always look at the final height or the target height of these children. Can we learn maybe more about malnourished children that are known in third world countries? This is an example of a catch-up growth in both boys and girls in rural Gambia. And as you can see, there is a catch-up during puberty, in boys even more than in girls. And this puberty is prolonged, so it doesn't stop at the age of 18, but they have an extended pubertal growth. We can see the same things of catch-up growth in other cohorts from Brazil, South Africa, India, and Guatemala and the Philippines. And this is all in the absence of nutritional supplementation. So does this mean we have to do nothing because they will have a catch-up grow anyway? I would like to think not. Maybe this is an extra opportunity to have a multidisciplinary approach and have them seen maybe more frequently to really use this extended pubertal growth to have a better outcome in the end. And when we talk about growth and nutrition, is that the only thing? Maybe not. This is a study from 2022 where they looked at scoliosis, and in this study 12% of the EA adolescents had scoliosis, but they found that especially these patients had a reduced physical activity and a reduced exercise capacity. As you can see here, when compared to the reference, they have a total score of physical activity that is much lower, but also for fine motor skills, bowel skills, and balance skills, we see that these children with scoliosis have a lower capacity. And in 2023, there was another study looking at physical activities. They saw that the amount of physical activities between EA patients and healthy controls were a bit the same, but they used a lower intensity of having their physical activity. And what's especially important is that those children with a lower height for age had a really significant association with the lower physical activity. Of course, we do not know what's the egg and what's the chicken, but maybe it's important to have some to think about that. And is it important to have physical activity? Well, this year a study was published by Oppenheimer that achieving and maintaining a muscle mass and having a good muscle mass in childhood and adolescence is very important to have as a preventive strategy for a good lung health. And of course, in EA patients having also respiratory problems, maybe we have to think about lung muscle and muscle mass as well. These are things we already know from other diseases such as cystic fibrosis, and maybe we have to consider this in EA patients as well. What I would think, and that's my personal opinion, if we need to have future studies on malnutrition, it would be important to have a follow-up that it's prolonged until the age of 2021 because of this extended pubertal growth. When we think about diet intake and diet follow-up, it should be at several moments in life. And not only we have to think about the amount of calories, but we also have to look at the quality of calories. Because if we say to children and infants, let's put some more fat into it so you have a catch-up growth and you have a catch-up weight, maybe if they keep continuing this kind of fat, they will have later on obese adolescents. When we look at growth and nutrition, we need target heights, we need parental heights, and I think we also need to know what their physical activity level is to know what we are talking about. This consensus guideline on transition is published last year, and as you can see, they tackle a bit the same thing as I just mentioned. There is malnutrition that decreases with age. GERD has an adverse effect. We do not know what the prevalence of EOE is in these feeding difficulties and this poor growth. All these children should be screened by a dietitian and a speech therapist. It has an impact on the quality of life. It's important in development of eating disorders to have a good screening tool. The predictive factors are not so easy to tackle. Probably a history of underweight is important. Follow-up should be multidisciplinary. And there's no data available on the effect of nutrition at this time. So then I conclude with some take-home messages. It's important to know that there are two periods of extensive growth, not only infancy, but also puberty. So maybe we need to adjust our consultations and see them more often at infancy, but also more often at puberty. When we look at help of the dietitian, we need we need to know about the quality of the calories because we do not want obese adults. There's a need for long-term multidisciplinary follow-up and transition. The systematic review of Brooks that I already talked about showed that 10% of EA adults had no healthcare providers, so that's a quite large amount. And when we talk about multidisciplinarity, we want paramedics, dietitians, speech therapists, it's already been mentioned, but maybe we also need a physiotherapist, not only for respiratory problems, but also for having an idea of what their physical activity is and what the quality is of their physical activity. We need a psychologist, and of course, we need some physicians for all the different systems. Thank you.
Thank you very much, Saskia. Yes, Simon.
Thank you for that very nice talk. I've got a couple of questions. Firstly, do we know anything about body composition in adolescence? I mean, you've shown some nice data on growth and anthropometrics. Do we know anything about body composition?
Well, there was only one study who mentioned that there was obesity.
But nothing in terms of lean mass or fat mass or
not what I'm aware of. No, okay. No.
And what do we know if there's any consequences? And I liked the fact that both yourself and Frederick showed this graph of the fact that stunting may get worse again in puberty. Are there any consequences for that? Do we know about delay of puberty? Anything like that?
Often there is a delay of puberty.
Yeah.
It's not that it's really proven, but on the other hand, we also see an extended pubertal growth. So probably at the end, there's still a little bit of catch-up.
Yep.
Yeah.
And then the final thing is we've heard from lots of specialties, rightly so. I've not heard anyone talk about dentition and dental aspects. Any interest in that or any knowledge on that? I can't think of any specific reason why it would be an issue in esophageal atresia, but if you have these scenarios where there's continual delay in dysphagia and potential reflux as well, then dentition is obviously of interest.
I think you're completely right. I didn't really did a search on dentical issues, but I can imagine that having the amount of reflux that we see, that it would certainly play a role.
I'm not aware also on any study on that, but it's very important and very good questions. There have been studies on dentition in GERD, there have been in chronic cholestasis, there have been in cerebral palsy children, but in esophageal atresia, I'm not aware of any, but there are perhaps.
Yeah, thank you. Very nice talk. Thank you very much. And so about the lower physical activity and the scoliosis and of course malnutrition and how the respiratory symptoms interact with malnutrition, making it worse maybe. Do you know anything about the lung function in these children as well? Because actually, of course, they had chronic maybe reflux, maybe several lung infections early in life, trachomalacia.
Yeah, I did not really do a search on that, but like I said, I think that what we can do is maybe replicate also a bit from cystic fibrosis. So I can only imagine that it will not be good. I know that in our center we always do lung functions. I don't know if it's really that problematic, but it's definitely something that we need to take into account. And seeing that muscle mass is an important role for a good respiratory function, maybe we should focus also on the physiotherapist.
Okay, if there are no more questions, we should move to our two clinical cases. Do you want to start with yours or whatever? Yeah. What is your order? Is there any mine? So if you want to relax a bit, so no. Relax a bit, take a coffee, and then. So Madeleine Omar is PGI in my team. So and she will show you the difficult cases of Kenza, and of course we've focused on nutrition and growth more than surgical issues. There are many surgical issues, but that's only to focus on what happens in terms of nutrition and nutritional support in this cancer.
Yes, better like that. This is a slide that have been prepared by Mathieu Antoine, who is from our team and who is following this difficult child, as you will see, with challenging questions. And that's this is a child who has been hospitalized a lot, and not in surgery but in our ward because of all these nutritional problems. So this was a girl, so she is born at 30 weeks, and she has a postnatal diagnosis of esophageal atresia with a tracheoesophageal fistula, but without any other malformation. She had first difficulty because she had surgical repair at D1, but mediastinosis, anastomotic leaks, medically treated, and she has, as recommended by ESPGHAN, an early start of PPI. During the first months, she needed parenteral nutrition from D1. And then she had enteral nutrition by breast milk on a nasogastric tube, and then, yes, discontinuously because of the different surgery, and it has to be stopped because of vomiting. And she had also discomfort. Then she had a possible oral feeding start on day 18 when she resolved where is the pointer? Here, where the anastomotic leak has been resolved. And so at first she was discharged at almost 1 month from the hospital. But 4 days later, she came back for an aspiration pneumonia due to the tracheoesophageal fistula recurrence and an anastomotic stricture. So we had to restart parenteral nutrition, and we had to stop oral feeding. 20 days later, she had another recurrence of pneumonia, and while she was on nasogastric tube feeding because of GERD. 10 days later, we placed a gastrojejunostomy to feed her in the jejunum because of this discomfort and this GERD. At first, it was well tolerated, but at 3 months of life, so 1 month later, she needed to be transferred to PICU because of another pneumonia, aspiration pneumonia. So she had these 48 hours of high flow oxygen therapy, and we needed to be stopped by enteral nutrition. So you can see here her growth, which is not so great at first. She had at 3 months and 4 months, we tried to close the tracheoesophageal fistula with acid applications. At 4 months, we placed a venous central catheter because of the need of prolonged PN, and we stopped enteral feeding because of GERD and aspiration. So that's these different things that you can see on her curve. So very poor growth. And then at around 4 months, she had PN, and so the growth has been up. And then at the age of 6, she has a surgical closure of TOF with an intercostal muscle graft interposition, but has had another mediastinosis. 1 month later, another diagnosis of TOF recurrence. And so she restarted post-pyloric nutrition on gastrojejunostomy, and had another aspiration pneumonia with another need of oxygenotherapy. And so that's what you can see here, another aspiration pneumonia. And here, when we stopped PN and tried to recommence on gastrojejunostomy feeding. Then at 9 months, she was in exclusive parenteral nutrition, and the failure of enteral nutrition was because of GERD. So we decided, and TOF, of course, and we decided to perform a fundoplication. So she had one, and we tried after a restart of enteral feeding, 5 days after the surgery, but she had the leakage of the Nissen, the fundoplication, and so we had to, and she has a vomiting recurrence, etc. And so we had to stop again enteral feeding. At the age of almost 1 year, 11 months, she had a new tentative attempt to close the TOF with this time nasopharyngeal covered stent. She had it during 2 weeks, but it was another attempt, but we didn't manage to close this TOF. So at the age of 15 months, she was discharged at home with home PN and a gastrostomy to drain the stomach. So by this day, so we are here on the curve. So yes, here she was capable to come back home. She had had PN in this time, so she had a growth that was quite correct. And after, and by this day, she didn't have any more aspiration recurrence when we were using exclusive parenteral nutrition. So it was our last, no, it was not our last attempt to feed her in the stomach. So at the age of 16 months, she had a third surgical closure of her TOF with a polyester patch. That's what you can see here, but yes, she had another complication of this procedure. So 2 weeks after surgery, we tried to progressive rehydrate her only with water, oral feeding with water, and she had immediately respiratory feeding distress, another aspiration pneumonia, and another recurrence of TOF recurrence. So it wasn't a successful procedure. We tried to feed her through gastrojejunal feeding, but even with the breast milk, she has a very motivated mom. She had also aspiration pneumonia. So at the age of 1 year and a half, she came back home with home parenteral nutrition. So you can see that on her trace, on the curve, yes, that she's growing great when we go with parenteral nutrition, and then it will be possible to start again to use her guts. At the age of 19 months, she was readmitted in the hospital for a sepsis and for hematemesis. Because of the ejection of the prothesis, the patch that she had in the TOF. At the age of 20 months, she has a new esophageal with another methylene test, and it was the first time that this TOF has been closed. So even if this patch has came in the esophagus, it has been successful to close it off. But she had the diagnosis of fistula between one of her bronchi and the esophagus. And so retrospectively, it was for this reason that she had hematemesis. It wasn't hematemesis, it was a hemoptysis. And that's when we took the decision to perform a lobectomy, the right upper lobectomy, and to stop trying to feed her in her stomach or after the pylorus because of her multiple aspiration distress and hospitalization in ICU. And so we tried to optimize her at maximum before the surgery with PN, with respiratory, with a physiotherapist, etc., to be on the best as she could for this surgery. And so she had it at 20 months and 12 days. And we were able after that to stop PN and to wean her from PN, and then to progressively feed her through the gastrojejunnal tube. And then she is for now at home, and she didn't came back. So. That's a present situation. She is now with post-pyloric nutrition. She has just two years. She's 2 years and a month. It's isocaloric semi-elemental diets. And progressively, without telling us, their parents tried home-blended food, but at least she didn't come back to the world, so it's okay for us. It's well tolerated. She is capable now to be clumped in the stomach for 5 hours a day, so that's step by step for her. And she is, of course, stimulated by oral feeding and speech therapists. So that's a difficult story of Kenza, but she's now better. You can see it on her. So that the weight here, so she's now very, very well after the cessation of PN, this lobectomy here, and she had this gastrojejunal exclusive feeding, which seems to be great. She has a height which is not so bad, and you can see that this is her head circumference, which is not so bad too, or growing. And you can see in resume that she has been really undernourished at first, then during the different recurrence of the TOF, and just right before this lobectomy. So our take-home messages were that in this case, she wasn't capable to have oral feeding because of persistent TOF. But we were not capable to feed her in her stomach because of GERD also. And we're not capable to feed her post-pyloric because of these multiple respiratory distress that have been in her history. And we believe that it's because of gastric hypersecretory when we feed in the post-pylorus, but also microgastria maybe, and very severe GERDs, and this persistent TOF, of course. So this patient had a need for home parenteral nutrition, and as Frederick said, it has been lifesaver for her. And after we were capable to restart post-pyloric feeding after this surgical procedure that has been a great situation now for her, and so she's on the way of an oral feeding rehabilitation, and maybe she will, we believe, need another fund application.
So very difficult case, and you understand that we had to adapt nutritional support to the situation. And what is underlying here is that it's needed a very close collaboration between surgeon and nutritionist at large. And we are lucky in our center to have our word close one stage to another one, to have a home parental nutrition program. So that's not a big issue, even if it's complicated, it's expensive. We have to train the family. But due to this very complicated case, it was the only option we found to save, gain nutritional, improve nutritional status, and now we expect that she will go on improving things.
But as you can see, we tried a lot to. It was difficult for us to abandon on her guts and on the gastrointestinal feeding, and so we tried and tried and tried again. And so then at the end, we said, okay, we go on parenteral nutrition, but it's not really automatic in this case because our in our ward we have patients who really can't eat without parenteral nutrition, and that's not her case. So it's not a classical point of view, but it was really a great thing for her lungs, that aspiration stopped and that we could go on with the rest of her taking care, yes.
Have any of you an experience of prolonged parenteral nutrition in such situation, or difficult case on that? No. Yeah.
Thank you. It's a very interesting case of you underlined the collaboration between gastroenterology. I don't know if it's possible to do some consideration from a surgical point of view, because probably I changed the strategy before. If sometimes some esophageal doesn't work, so you needed to substitute the esophageal perhaps before, then after 2 years, probably we don't lost the upper lobe, and then I don't know, in the strategy to close the TRF, actually we have also the vacuum endoscopy possibility, and I don't know if you have a trial.
It was a question a lot of time, and we had a lot of meeting with our surgical team because of this question. Kenza has also parents with, as you can imagine, a very difficult life around. She's the third of a family, and the parents have very. They had their idea, and they didn't want esophageal replacement. So it was one of the things. They are not so easy to deal with sometimes.
Yes, thank you. It's a very impressive presentation, and I think a very difficult story also for the team and also for the family, of course. The timing of the re-thoracotomy to close, actually, then she was on the lowest part of her growth. And could you have like gotten to a better nutritional status, also to get the best chance out of that surgery? Because you also probably would have like multiple chest infections at that time as well, taking all her calories. And so that would be one of the things I would worry about most, because if you have children with recurrent tests, usually the morbidities, they're undernourished, very bad respiratory condition, and also cachectic. So that's something, maybe then parenteral nutrition could help. We would always try to drain internally, like with a vacuum or a replug tube locally, just to prevent also a microaspiration continuously. One drain in the stomach to get the reflux out, and then also feed on the post-pyloric and get them into a better health status, and only then consider major surgery. I don't know. Yeah, of course. Yeah, in hindsight, maybe at that time, but I understand why you did.
Yeah, we of course, probably this case was discussed nationally with different cases. Ronnie asked many colleagues to have advice and so on. So we discuss every stuff with this child. Probably looking back to the case, we should have tried something else, because She was more than 1 year in hospital. If you combine all the time, the only way to have her back home was home parental nutrition at that time, to improve and wait that she would be better, and went to the lobectomy because of this fistula and the different failures. So we didn't have the experience of these aspiration systems. So interposition, stent, everything failed. But when you start with these difficult cases, and I absolutely agree with you that undernutrition is a cercle vicieux, is a vicious cycle where there are more infection, tissue are not well for the surgeon, is not. Yeah, exactly. Yeah, exactly.
I only recently moved back to Europe, and so all my experiences in the US, and one of my partners in the US had one similar to this, and also ended up having a bronchoesophageal fistula that was managed with an NE tube and a vac at the site of and that allowed them to get through all the aspiration, the lung to heal, everything to calm down, and for them to successfully operate. So it's just another option that I think is interesting.
NE aspiration? That's I'm not sure I didn't I understood well.
Nasoesophageal, sorry. Yes, we spell it differently in the US. A nasoesophageal tube, and then also an endovac at the site of the fistula.
Okay.
Okay. Yeah.
Hi, Martina from Milan. Thank you. We also had a very difficult case, a bit similar than yours, and I think I wish we had gone for parenteral nutrition earlier, because we really struggled with the feeds, because she was tolerating the post-pyloric feeds but not really catching up with growth. And so I think it is an option, and I'm not sure that losing the upper lobe is better than losing the esophagus. So I think it's a tricky balance.
Okay. So thank you, Madeleine. Again, Saskia, for your. It's no so complicated case, I think, no?
No, it's just another video of sham feeding that we wanted to share. It's not so spectacular as the sham feeding from Sweden. So it's a girl born at 32 weeks of age with a weight at 1,100 grams. She had a low gap esophageal atresia. In another center, they binded the fistula, give her a cervicostomy and a gastrostomy, and then she was referred to her hospital at day 60 with an esophagus gap of around 7 centimeters. And when she arrived in our hospital, we started sham feeding. There was a delayed primary repair by Kimura. She had 10 elongations and then an anastomosis in August when she was 8 months of age, needed 11 post-operative dilatations. And then 1 year later, she was on full PROS intake. This all happened in a revalidation center because these were very young parents, teenagers who could not really take care of their child themselves, and then ended up in a horrible divorce. Today she's 5 years old. She's going to school, lost her gastrostomy at the age of 3. She hasn't been admitted at the hospital for the last 2 years, and she's 4 monthly seen at a polyclinic. So this is the sham feeding.
So thank you for this case. So I don't know if you have suggestion or comments on this case. Yeah.
Thank you so much. I think this video is a really interesting point to think about quality of feeding as well as the opportunity to sham feed, which is clearly important. Actually, it's really important that observational assessment is carried out so that we make sure that it's always a positive experience for the child. So that child clearly was showing signs of hunger. They wanted the food, but every time they swallowed, they coughed and started crying. And I think that's a really important thing to think about. What are we setting up for a positive feeding experience, and the importance of making sure that it is well supported, and that there is a multidisciplinary team around that child helping promote positive oral feeding experiences, as well as just saying we need to sham feed. Just a comment.
So please speak in the.
Work through with the child so they don't have a negative experience, or is it that you, in this case, would stop sham feeding?
No, I definitely wouldn't stop sham feeding, but I'd want to be making sure that the person who is feeding the child was aware of those child's cues. Absolutely, we should be because if you have a child like that and we just stopped, absolutely when they're repaired, you come to try and feed them and there's a problem that's going to be even more entrenched.
15 minutes.
Yeah, Alex, from your point of view, would this child has a STOMI, and we saw the example of the tube going down. Would you consider in this child, if you have a tube down, to pull it up so you can suck it out earlier? Is that something that could help, or is it
the tube?
Well, like the nasopharyngeal tube that was shown in the Swedish video. Would that be better or worse for this type of symptoms, or is that hard to say?
Yeah, I think it's really hard to say. Yeah, I'm not sure that we know the answer to that question, actually.
Okay, if no more comments, we are just moving in the last part. We have 15 minutes maximum, and so 3 of us have take notes and listen what is happening and what happens during this session. And so Simon will start because he take notes, and then Stefan, and then you will also add your own notes. And the idea is we have all the slides. They will be available on the website of ERNICA if some of your healthcare providers or any staff members wants to look at them later on. And we are thinking, and so that depends. So if within ERNICA we make a report or publish or place it in the summarizing everything we heard this morning, this afternoon. So Simon, if you want to start.
Okay. Yeah, so I think all of us have made notes, so I'm just going to very briefly mention a couple of points that I picked up on from Michael's first talk, which were, first of all, that fundoplication might make the dysphagia worse, although the GERD might improve. Is that a reasonable summary of what you were saying? That you can't predict that fundoplication is necessarily going to cure the dysphagia. Yeah. Higher risk of EOE, and also I think this question was interesting, right? That you posed right at the end of when to treat the eosinophilic esophagitis, whether early or late intervention is the best in that. I don't know if Joanne or Stephanie have any comments on Michael's.
Yeah, Michiel, maybe himself as well. I don't know. Actually, I also noticed the difficulties about the fundoplication, maybe giving more complaints and limited success. seems like a challenge for the indication. And also the manometry pre and post fundoplication, I think ought to be obligatory in these patients. And one thing also I know is that motility drugs don't work due to the abnormal esophageal constitution, actually. So maybe that's something I learned today. If you look at the slides, and maybe we should also look at more the complete esophagus, and this might be the reason why things don't work as we hoped for.
Well, I think it's really important that you explained what can go wrong in the esophagus, and also that you can explain it to parents very well, so they can watch what they have to, so they know what they have to watch for and when they have to come back.
So, second man, you are happy with that?
I think they listened very well.
Yeah, they listen well. You were the first, so we will see if it's still. Okay. So Simon, you go on.
And then Anne-Marie and Jan. Jan, I've great criticism of the way you applied statistics, though, you'll be pleased to know. But no, I think we were all really impressed by this beautiful video and the impressive results of your protocolization of sham feeding whilst waiting for esophageal reconstruction. And also, I think it was impressive the early oral feeding after esophageal continuity was restored, and that's a tribute to, I think, to the success of your sham feeding protocol. But also, I was interested in the satiety aspect there, that you think about that as well as just the oral sensation. And so it's something you touched on but didn't really talk about. I don't know if you'd like to comment on the satiety aspect of that.
Thank you. I think it was rather a way of telling the audience that we should look at this on a holistic view, that feeding is not just calories, that including oral maturation or a motor function, protecting the airway, and the concept of satiety. If you have continuous feeds, if you just get feed every 3 hours because there is a clock saying that there is 180 minutes later, that doesn't really work in the normal life. So if you can do this, the child eats, and at the same time as the child eats, the child gets full. Then if you can, that's, I don't know if you call it a reflex, but that's at least some cerebral imprint or whatever. So that's why we think that is good. Anna-Maria, obviously, you probably know the answer to this question instead.
Perhaps you need to translate. But of course, if there are... if it is a grossa and they have a very small stomach, so of course we can't bolus immediately. So then a bit of training time for the stomach when we sham feed, but we're aiming for eating and the baby feels satiety and have more normal habits. Okay.
And that probably also drives the idea of eating afterwards. And then if you learn that before your operation, then if you learn that concept before the operation, then it's probably easier to. Of course, everything we do is guesses, but that you actually, if the child is hungry, there may be stimuli actually to try to eat and feed orally.
I was impressed actually by how strict you follow this physiology by giving the feed exactly at the same time while the baby was swallowing. Is this something they do at home as well, or do you give them a pump?
They have a pump as well, because especially when they are small, sometimes it's better in their life. And some of the children go home before they are full speed up to full meals. So then a pump can be a help for the parents. Yeah. They could do that in the beginning or at night if they're tired. Yeah. And so I'm sorry, what was the main question? Yeah, that was the question.
The concept is running of two syringes. So for the daytime, for the child is alert and awake and the parents are the same, we have one syringe out and one syringe in. So that is a momentarily reflex in the daytime.
I think another advantage of your approach is that the parents are responding to the child's cues around hunger. And that is a huge thing post-repair, that they are already understanding when their child is hungry. And so they can respond to it. And that is how you get effective oral feeding.
Because usually post-operative, the parents say, my baby is hungry, can we increase the food? And we go to the surgeon, but please, now start full meals. Yeah.
And just to finalize that, because what Anna Maria said, you usually go to the surgeon, and that's one thing that we're also trying to take away. We're going to try to take away the decisions away from the surgeons, because the surgeons say today you could have 5 meals, today you could have 10 meals, and there is no reason why there should be a numeric value of what the child eats. And and maybe it's not even the nurses, maybe it's even the nurse assistants, the ones who actually spend 24 hours with the child in the high dependency unit. So maybe it's not even our decision whether the child should eat or not, because the child tells the parents and the nurses when the child should eat. It's not the surgeon who should say that. So that's a part of that concept of taking those decisions a bit down.
Stefan?
Yes, I totally love the video, also in the presentation. I like it that you call it the Stockholm Protocol, and the 4 cornerstones are addressed. Very much empowering for the parents, taking away from the surgeon, at least, as far as we can. And when I saw the video, I thought like the ideal Stockholm situation, having 3 parents to get it all working. But then I see you have other kids involved as well, and mothers can do it on their own, like anything together. I do wonder if it would be helpful in any country, in any situation. I mean, it's a very multidisciplinary approach, empowering the parents, and I can feel some reluctance. There could be some reluctancies in other countries with not the same similar settings. But I think if we should if we've seen this, if you have delayed primary anastomosis, which is very often most applied, I guess, then sham feeding should be one of the best options, and otherwise you should make this a very trainable protocol, so to get it more out. So home feeding is safe, but you have only, of course, limited experience, and of course you want to keep it safe that way. So, but yeah, I love it.
Johan, so yeah. We are.
Well, a few other things you said as well, that the importance of a qualified team is, I think, very important, and you take the time to teach parents about this. And that's really great. But do you see now that you also, the other parents, because there are much more parents with not a long gap, no sham feeding, do you take more time for them as well, because they need it as well, I think.
Okay, I'm sorry, because we have to summarize all the session, and we have only 5 minutes left, and then we will do. So if we can go on. The next point for you.
Yeah, sorry. So just very briefly to summarize from Woko, what I learned was, first of all, the model of the stress bucket, which I'd not heard of before. And I mean, all the factors that could lead to PTSD in the parents of these patients. And I really look forward to the self-help tool being finalized.
Same for me, actually. It's empowering the parents as well, and the importance of that, I think. And yeah, looking for tools how to measure the stress and to help parents in their role.
I think she showed the importance of a psychologist in our multidisciplinary team.
Yeah.
Yeah. And then moving on quickly. So Alex, I thought. I mean, really impressed that your passion for saying that we need a proper feeding assessment before these children are discharged on full feeds, to try to make sure that feeding cues, etc., are being instigated properly.
And for me, actually, that's one of the questions I also had. Like, we need, if we're going to publish our results, not like especially surgeons that we do, and say, well, I did have least complications, but we need better follow-up with these patient-related outcome measures. Very, very important.
Johanna?
Yes, just not start when there are bigger problems, but start at the beginning with the salt therapist.
And then from Frederick, I learned about poor growth during puberty, the fact that oral nutrition supplements, we need to take care. We're not sure of their use, and we have to take care that it's not used as a substitution. That blended foods could potentially lead to a nutritional imbalance due to the use of the same blended food all the time, but also dilution with water, so potential for undernutrition. And I also learned that butter is really important in northern France, and olive oil is really important in the south of France.
So you make the major point of this meeting. Yeah.
But still, in the children's group from 1 to 3 years old, 42% are not on the normal diet. It's, I think, is very important. And also measuring head circumference is not always standardly done. I think is one of the things we have to look for, because there are some publications that children born with EA have below par head circumference.
Nothing more. Okay.
And then for Saskia, I was impressed with the focus on physical activity, and also the potential interaction with respiratory function. The fact that we can't look at all these things in isolation. Also, the opportunity for catch-up growth during puberty. Then we need to extend follow-up to the years at least 20 or 21 years age to allow us to capture that catch-up growth, and also to measure against parental or target height.
To me, it was like the chicken and the egg story between lung function and malnutrition and the morbidities, and they kind of interact all the time. Of all the studies you discussed, the 25% have a low or too low BMI, 1/3 is below their target heights. That's impressive, and that's a result of our treatment, which we've done so far, and which you can't correct anymore. So I think that it just stresses out the urgency of why we're sitting here today. This is something we have to address now, because we're doing not well at this time. I don't know what stenting is, but I'm a surgeon, so I'll Google it later. Thank you.
Well, I think my boy from 17, he will be very glad that he has a little bit chance that he's going to grow a little bit bigger now from now on.
Okay, we are just on time, 30 seconds. So I really want to thank all of you, all the speakers, because from my point of view, it was a great session, because it had very cross view and complementary approach on this very important topic. What will be done is we will take the note of our 3 specialists, and I want to thank you very much for helping us to organize everything. It was very nice. And so she will put all together, and we will put a report, very simple, most of the things. We have also your slides. So thank you, Sarah. Thank you to all of you. Thank you to the speaker, and thank you